Hello everyone. So today we will be discussing about pelvic organ prolapse. So what is pelvic organ prolapse? You all know that this is uterus, this is cervix and this is vagina. So due to the force of the gravity, increased chances are there that this uterus, because this uterus is very massive organ, it can come inside the vagina or even it can come out of the vagina. Okay, so but this usually does not happen. Okay, why is it so? Because uterus is supported by some in the pelvis by some supporting structures. Okay, now we will discuss all these supporting structure, and when the supporting structures they fails, then it is known as pelvic organ prolapse. Okay, when these supporting structures fails, then it is known as pelvic organ prolapse. And in pelvic organ prolapse, this massive uterus, it first comes into the vagina and even it can go out of the vagina. Okay, so there are three levels of supports. First is primary support, second is secondary support, and third is tertiary support, depending on how much they are contributing. The one which are contributing more to support the uterus are the primary support, which are contributing less than primary are known as secondary support, and the one which is just a mild support are the tertiary support. Okay, so in secondary support, out is the round ligament. Okay, so in secondary support is the round ligament is not so sturdy to give the support, and in the tertiary support is the broad ligament is just the peritoneum. So a delicate peritoneum cannot give support, but it gives a mild support, so it is in the tertiary support. Okay, so now let's discuss the primary support in detail. Okay, so these are the three types of primary support. Okay, number one is the uterine axis, number two is the muscular support, and number three is the ligament support. Out of all these, this muscular support is the most important. Okay, now first we will discuss uterine axis. Okay, see above here the uterus, cervix and vagina. In the above black colored diagram, uterus, cervix and vagina, they are not in the straight line. Okay, they are not in the straight line, they are at angles. Okay, as you know, the cervix is in the mid, so cervix also makes an angle with the uterus, and the cervix also makes an angle with the vagina. Okay, so when the what is the angle which the cervix makes with the uterus? Okay, the angle which the cervix makes with the uterus is known as the angle of anteflexion. Okay, and this angle, as you know that we can make an angle only with the axis. So this is a uterine axis and this is the cervical axis. So this angle is 170 degree. Okay, so you all know 180 degrees the straight, and the 170 degree is just a slight bend. So uterus is only slight bended with the cervix. This is known as angle of anteflexion. Okay, now the angle which the cervical axis makes with the vaginal axis is the 90 degree, and this is known as angle of anteversion. V for vagina and V for version. Okay, a mnemonic for you to so that you can easily learn. This is the cervical axis and this is the vaginal axis, and this angle is 90 degree. Okay, okay, I hope you understand. Now, what is the advantage of these angulated uterine axis? Can anyone tell me? What would happen if the cervix, uterus and vagina were in the straight line? Okay, first if they would have been in the straight line, then the gravity would have acted more. Okay, now when they are angulated like this, So now their pressure or the mass of the uterus is beared by the nearby organ. So this is the bladder. So as you've seen, so here when due to the anti-flexion angle, because the uterus is quite bended on the uterus, sorry, the uterus is quite bended on the bladder. So most of its mass is beared by the bladder. Okay, so in this way sharing of the mass occurs, and gravity acts a little when it is angulated. Okay, now question was once comes in NEET PG, that angle of anti-flexion is maintained by which ligament? So the answer to this is of course round ligament. So let's study how. Okay, so if this is uterus, round ligament starts here from the fundus. Okay, round ligament starts here from the fundus, then it goes to the lateral pelvic wall. You all know that uterus is inside the pelvic wall. Then it comes out of the pelvic wall. See here in the image, the uterus has this from the fundus the round ligament originates, and then it comes out of the pelvis wall or the pelvis bone, and it goes inside the inguinal canal. Now this structure is inguinal canal. Then it comes out of the inguinal canal and insert here. This structure is labia majora. Then it get insert at the interior and the at the interior end of the labia majora. So what happens when it inserts at the interior end of the labia majora? Suppose I am uterus and this are the round ligament. Now you all know that labia majora is at the anteriorly and at the lower. So when this round ligaments go and insert there, this downward and the interior insertion of the at the labia majora bends the uterus slightly. So from rather than 180-degree, this uterus it bends 170-degree. Okay, okay, now let's go to the next slide. You have seen that that was all about the uterine axis. The another question is about the muscular support. Okay, muscular support is by the three muscles. See here in the diagram, this structure is the levator ani. This structure is the uterus. This is the urogenital diaphragm, these both, and this is the perineal body. Okay, this is the perineal body. So these all these muscles, levator ani, as you have seen in the diagram, urogenital diaphragm and the perineal body, they hold the uterus and support the uterus so that this uterus does not get prolapse. Okay, so see here in the camera, if this is uterus and my hands are levator ani, the diagram which you saw here in this image was a longitudinal section. The one which you are seeing here in the camera is the 3D image. So this is the uterus and this is my hands are the levator ani. So like this they are supporting the uterus. At the bottom there is quite strong support. Okay, so this levator ani is the most strongest of all, and as we have already discussed, the muscular support was the main support, and among all this the levator ani is the most strong support, because this levator ani has got very large strength. Okay, now these are the muscles of the levator ani, and this is the transverse section. Okay, this structure, this round structure is the cervix. So you can see such a large strength of these muscles is and these all muscles are inserting in the pelvis. So this is the pubococcygeus, this is puborectalis, and this is the iliococcygeus. Okay, so like this, they come from the pelvis and the they hold the uterus quite strongly. Okay, and this levator ani is quite massive. Now let's study about the ligament support. You all have studied these ligaments. Let me show you this in this camera. Suppose this is uterus and this is the my pen are the ligaments. So two ligaments arises is from the cervix, the lower, if this is uterus and the lower end of this is cervix, and these two ligaments are arising in here transversely, and they go transversely and insert at the pelvic wall. Now same here we will see in the transverse section, right? See, these are the this is cervix, and these are the transcervical ligament, and they have inserted here into the pelvic wall. And now you can see in the diagram also that these are the most strongest. They looks as the most strongest, right? So these ligament, transcervical ligament, is also known as McEnroe ligament, and it is also known as cardinal ligament. Okay, so I told you that this is uterus, and these two are the two ligaments which are coming to the cervix transversely and going to the pelvic wall. Okay, now two ligaments come from the anterior end of the uterus, and they get insert at the pubic bone, because anteriorly there is the pubis bone. Okay, so as you know, anteriorly to the uterus is bladder, so they also engulf the bladder. Okay, let's see this the things in the diagram cut section. So from the anterior end, these two ligaments have arisen, they have bladder in between, and this is the bladder and this is the ligament, because they get insert at the pubis and they arise from the cervix. This is known as pubocervical ligament. In the same way, two ligaments, they arise from the cervix and get insert at the sacrum, and in between them this is the rectum. So this is known as uterosacral ligament. Okay, so these are the three ligaments. Out of these three ligaments, McEnroe ligaments or the transcervical ligament are the main ligament, and that is why they are also known as the cardinal ligament. So this was all about the supports of the uterus. When these supports they get weak, they become weak, then the prolapse occurs. Then uterus comes in the vagina, or the uterus comes out of the vagina also. Now let's see what happens when the uterus come out of the vagina. As in the diagram, you see this is the normal anatomy. Okay, and here this side it is the prolapse. Okay, now when this uterus comes down, see here, not only the uterus is coming down in the vagina when the supports get weak, then this bladder also come down, because in the nature, in the human being, in the human female, they are not placed separately, they are joined by fascias. So when they come down, the adjoining organs, they also come down. Okay, and here you can see that, see this anterior vaginal wall, and this is the posterior vaginal wall, these two are coming down. So there is not only the prolapse of uterus, there is also the prolapse of the anterior vaginal wall and the posterior vaginal wall. Okay, now see, this is the bladder, and this bladder which gets prolapsed is known as cystocele. Cystocele. And this rectum which gets prolapsed is also known as rectocele. Okay, now let us discuss the etiology of the prolapse. Okay, why this prolapse happens and why. Okay, okay, let's see. You know that this is the uterus and this is levator ani. Now this levator ni, it has two tone. Number one is the neural tone. Tone means that its entirety is made by two structures. Matlab its structure or its contracting power is made by two things. Number one is the neural tone, and number two is the estrogen tone. Neural tone means the nerves which are innervating the levator and eye. Estrogen tone means the estrogen's hormone in the body is maintaining its tone, its contractility, its power. You all know that at menopause the estrogen level they decrease, isn't it? The estrogen level they decrease, ठीक है, during the menopause, right? So when they decrease during the menopause, the levator ni power or tone also gets decreased. Okay, so when we are studying its etiology, we should know that during at menopause, due to the loss of the estrogen tone of the pelvic floor, this levator ni is also known as the pelvic floor. Okay, so anything so that due to this loss of this estrogen tone, the levator ni support weakens. Already discussed, this levator ni is the main support. Okay, anything which injures the levator ni or stretches the levator ni will decrease the strength of the levator ni. Okay, now let us see when this levator ni is stretched. Okay, this levator ni is stretched whenever there is pressure on it. Okay, now let's see when there is pressure on it. See, now I am making this uterus a pregnant uterus. You all know pregnant uterus is a big uterus. And now this is the fetus. Pregnant uterus is not only big, it is also have fetus. So lot of weight is put on the levator ni, which stretches the levator ni and makes the levator ni weak. So with every pregnancy, there is a lot of stretch on the levator ni and levator ni gets weak. Okay, okay. Now when this pregnant lady, if this pregnant lady goes through normal delivery, then this pregnant lady suffers a lot of contractions, and you know that uterine contractions has lot of pressure. So all this pressure of the uterine contraction is beared by this levator ni. So more the lady gets paras, more is the lady parity, more is the, yes, more is the later parity, more is the stretch on the levator ni. More the ladies undergoes through normal vaginal delivery, more is the stretch on the levator ni. So these are the two major factors. Now we see that if there is prolongation of the second stage, the most powerful contractions, the most pressure contraction is in the second stage. Now if second stage get prolonged, the levator ni has to suffer a lot and levator ni gets weak a lot. Now what if we cut short the second stage by applying forceps, by applying vacuum, or by a or by giving episiotomy. So it means whenever we are shortening the second stage, we are decreasing the stretch on the levator ani. So the chances of prolapse or chances of levator ani weakness will decrease. Okay. Now what if the forceps are not applied correctly? Let's see this. Now this is a pregnant uterus and these are the forceps which we applied. Now if they are not applied correctly, then close to them here is the levator ani. If faulty technique of forceps is there, then of course the levator ani will get injured. Okay, faulty, then levator ni fibers will get injured. So a good forceps is decrease the chance of prolapse, but a faulty technique forceps they increase the chance of prolapse. I hope it's clear to all of you. Okay, so let's see the question which came in NEET PG. Answer question is here. All of the following, sorry, it came in FNG December 18. All of the following events during childbirth. These all are the events during the childbirth. Which one of the following will not cause pelvic organ prolapse? Okay. First is precipitate labor. Precipitate labor. What is precipitate labor? In a short time, patient suffers large number of contractions. Okay, in short time patient gets large number of contractions. So pelvic organ prolapse will be there because patient is getting large number of contractions. No doubt the time is short, the waiter and I has stretched, and yes there were large number of contractions. Okay, then prolonged second stage again prone the patient for prolapse because it will stretch the peritoneum more than the normal. Premature bearing down. Premature bearing down. With every bearing down, the pressure, the stretch of the levator ani increase. So premature bearing down will also increase the chances of prolapse. Third degree perineal tear. Yes, third degree perineal tear injures the rectum, but when the injury of the rectum relieves the pressure to the levator ani. So only this third degree perineal tear is relieving the pressure on the levator ani. So the answer is third degree perineal tear. So what are the types of prolapse? As on the basis of anterior vaginal wall and the posterior vaginal wall. We have already studied that if the bladder comes down, and it comes down if the anterior vaginal wall prolapse. So if the upper two-third of the anterior vaginal wall or prolapse, then the bladder also comes down, then that is known as cystocele. If the lower one-third of the anterior vaginal wall comes down, then the urethra also come down, and this is known as urethrocoele. If the posterior upper one-third comes down, then the large gut also come down, and it is known as enterocele. If the middle one third also comes out, then it is known as middle one third rectocele, because rectum also come along with it. If the last one third comes, then it is known as lax perineum, because perineum is there. Okay, so that is what it is written here. Okay, I hope you understand. Now let's see how the prolapse is classified. Okay, okay, now this is bladder with urine inside it. This is rectum. Okay, Okay, and this is vagina. The original position of the uterus is somewhat like this, right? Now this, when uterus comes down, first it comes here in the vagina. Okay, this opening is introitious, the opening of the vulva. So now when the uterus is in, when the cervix, the lower end of the uterus is above introitious, then it is known as first degree. Cervix above introitious. Understand? Okay. Now, what is second degree? Second degree if the cervix is at the introitious. Now, this is second degree. Cervix is at introitious. Now, if the cervix comes out of the introitious, this is third degree. Cervix out or below introitious. Okay. Now, what is procedentia? We should also know what is procedentia. Okay, right? Now, let us see what is procedentia. Procedentia is if the fundus of the uterus is also outside. Okay, if the fundus of the uterus is also outside, then it is procedentia. Fundus is outside introitious. Okay, now the classification which we studied was Shaw's classification, and mainly four type of prolapse was there: first degree, second degree, third degree, and procedentia. But as you saw that in this only we are seeing how much is the cervix down or the uterus down. We are not measuring cystocele, rectocele. But before we studied, the cystocele and rectocele also happens depending on what is prolapsing, interior vaginal wall or the posterior vaginal wall. So the new classification was there, which is known as POP-Q classification. POP means pelvic organ prolapse and Q here means quantification. And this classification is universally accepted. It has 9 points in it. Okay, and it helps to quantify each and every prolapse. Okay, now if I have done surgery, then it will also quantify that at how much prolapse I have corrected. The uterus prolapse, how much I have corrected. The vaginal prolapse, how much I have corrected. The cystocele, how much I have corrected, and the rectocele, how much I have corrected. So it also will also measure, because I will just examine the patient before the surgery and after the surgery, and I will come to know how much I have corrected by surgery. So it also helps to quantify the outcome also. Okay, it also helps to quantify the outcome. So this is known as the POP-Q classification. Okay, you just need to remember this, all this point. I don't expect the question from this. Okay, this is a question from FMG December 21. Which of the following is the treatment of decubitus ulcer in uterine prolapse? Okay, one thing I would like to tell you, the number of questions which come on prolapse and the number of the questions which come on two topics, so two subtopics are the same, and those two subtopics are decubitus ulcer and prolapse, because practically these topics are handled by interns. Okay, so the examiners want that when you come for internship, you should be doing this things very nicely. So about decubitus ulcer and pessary, you should have a wholesome knowledge. Okay, so what is the treatment of decubitus ulcer was the question which was asked in FMG December 21. Okay, so now let's see what is decubitus ulcer? See, this is the normal uterus and this is the prolapsed uterus. Okay, now when this prolapsed uterus come downward, okay, not only we have already studied that not only this uterus comes, in adjoining structures, that is vagina also comes. So vagina also comes like this, right? Now not only the vagina comes, the nearby organs also come. That also we have studied. Cystocele, rectocele also happen. Not only cystocele, rectocele happen, the blood supply which are here in adjoining to the uterus, they also come down. Okay, now see here. I am drawing the blood supply with orange color. So this is the blood supply which has also come along with the uterus. Okay. Now here is the introitius. Are you appreciate? I will change the color. Now this is the introitius. Now you know that the introitius or the vulva opening is very small opening. So when this uterus comes down and this venous supply also come down at the level of introitius, there is venous congestion due to the narrow opening. Okay, and when the venous supply gets congested or gets obstructed at the vulva, so the uterus lower end, the lower end of the uterus, see this ends, they when get injured, here ulcers are formed. Okay, ulcers are formed. Okay, very soon the ulcers are formed because already they are having venous congestion. Okay, so the ulcers are formed and these ulcers are known as decubitus ulcer. They are on the lowest part of the prolapsed uterus. Okay, so as you have studied that this ulcer has been formed due to the venous congestion, so the treatment of this will be to reposition. To with the hand we will make the uterus inside. Now see, so we will get the uterus inside, and so that it does not get prolapse again, we will put here packing. Okay, or the another thing we can do is we can put here a ring like structure which is known as pessary. Okay, okay, so the treatment of decubitus ulcer is two things. One main thing is repositioning, and repositioning can be done by pessary or by packing. Okay, the ointment which gives heals the ulcer after repositioning is the acreflavin. Okay, that is what we do. When a lady with decubitus ulcer comes, we reposition the uterus so that the repositioned uterus does not come out again. Already the structures are weak, it will come out, so we will put a packing or a pessary and we will apply the acreflavin ointment there. Okay, so that was about the decubitus ulcer. Okay, now let's study the treatment. Okay, now at any age prolapse can occur. Okay, now the treatment of the patient who wants to conceive again. Okay, now we know in prolapse supporting structures have got weak. Now any lady who got prolapse in a younger age due to the levator ani weakness or due to the levator ani injury, then that lady we can't remove the uterus, or we can't do the surgery, any surgery on the uterus. We have to just, to support the levator ani, we have to apply slings. Okay, let's see here. Now this is the prolapse uterus and this is the pubis bone. So we will just apply slings here. So these are the slings. Okay, slings, mesh slings are there. So two type of slings operation are there: Pudandre sling operation and Shirodkar sling operation. Any of them one can undergo. The sling operation is for the lady who wants to conceive. Okay, the next surgery is for the lady who is less than 40 years but whose family is completed. The lady like me, I don't want my uterus to be removed in spite of the fact that I am having prolapse, because you all know that uterus does not only is for conceiving. Uterus also gives supports to the bone, prevent osteoporosis, and lot of menopausal changes will come to me if I get my uterus removed. Okay, so the surgery for those ladies who are less than 40 years and whose family is completed, we can handle the uterus. We can do small surgeries on the uterus. So what we do here is, just see, we are not going to apply sling, we are going to cut the cervix. Okay, okay, and you know that from the transversely McEnroe ligament arise and they get insert to the pelvic wall, and this cutted cervix, amputated cervix, the uterus with amputated cervix is fixed with this McEnroe ligaments. Okay, see, now this cervix has been cut and we will fix this uterus with the McEnroe ligaments by tightening the McEnroe ligament. So the tightening of the McEnroe ligament will prevent the uterus to prolapse. Okay, okay. So this was about the surgery for the ladies who are less than 40 years and whose family is completed. Okay, this surgery is known as Fothergill or Manchester surgery. Okay, now for the treatment for the ladies who are 40 years and whose family is completed. By 40 years, I want to mean more than 40 years and even older than 40 years. You know, some symptoms of menopause do come after 40 years, and if family is completed, uterus functioning gets decreased, estrogen tone gets increased. So here we can remove the uterus. So what surgery we do for those ladies who are more than 40 years? So here we completely remove the uterus. We completely remove the uterus, and we remove this uterus as vaginally. Why we remove it vaginally? Because you know that this uterus is also, this vaginal wall has also prolapsed. So we, and the cystocele also there, rectocele is also there, so we need also to correct this. Okay, so this is known as pelvic floor repair. Okay, so what we do after removing this uterus was, these prolapsed vaginal walls are there. So you will think that I'm just that this is, that we have removed the uterus vaginally, and now how we correct this vaginal wall? We do it by anterior. What do you mean by anterior? Anterior colpo Rafi. Let me tell you the name meaning. Anterior means interior. Colpo means Colpo means vagina, concerned with vagina, and refi means repair. Okay, so we do anterior colporrhaphy. So we also correct this vaginal wall, anterior colporrhaphy, and we also correct this posterior colporrhaphy. So anterior colporrhaphy plus posterior colporrhaphy is known as anterior colporrhaphy plus posterior colporrhaphy is known as pelvic floor repair. Okay, for the ladies who are more than 40 years and family is completed, we remove the uterus plus we do pelvic floor repair, and this operation is known as Ward Mayo operation procedure. Now, what if, as you are seeing that the menopause comes near 50 years, and these are quite old ladies, 50, 60 years, and what if they have simultaneously some other morbidities like heart diseases or any other problem due to which the anesthetist said no, you can't do a long surgery, you just have 5 minutes, do anything you want in 5 minutes. Then what we will do, of course we are not going to do vaginal hysterectomy and pelvic floor repair. So then we will do leaf forte colpoclasis. What is leaf forte colpoclasis? Just focus here. Now this is vagina, right? And this is cervix and uterus above it. Okay, and this is the cross section. Okay, now this is the anterior vaginal wall and this is the posterior vaginal wall. So what we are going to do is this, we are going to make this anterior vaginal wall and posterior what we are going to do, we are going to take this interior vaginal wall and posterior vaginal wall near. So what will be the result? It will be like this, right? Right, it will be like this rather than a round structure. So this is known as leaf forte colpoclasis. What is leaf forte colpoclasis? Leaf forte colpoclasis means, again I told you, colpo means vagina and clasis means fusion, fusing the interior and posterior vaginal wall. See here, this is the vagina. See, this is vagina, right? We have fused this interior and posterior vaginal wall, and in this way, now when we have stitched the interior and posterior vaginal wall, what will happen? Uterus, reposition uterus will not come down. Yes, and we can do this surgery in 10 minutes, 5 to 10 minutes. So the ladies who are having any morbidity or are quite old, cannot afford such a long surgery, for them we do leaf forte colpoclasis. Now what if the lady has got lot of morbidities, and if the anesthetist said no, you can't even do for 5 minutes, then what we will do, we will put a ring, pessary. Okay, because with the pessary the uterus will not come down, but pessary has its own complication, but still problem will get solved or up to some extent by putting the pessary. So indication of pessary are, two more indications of pessary are there. One indication is in the early pregnancies which are less than 18 weeks. Okay, there if prolapse is present, we can put the pessary. And the another condition is up till postpartum 6 weeks, because again we cannot do the hysterectomy or the for the gill Manchester repair in puerperium period up till 6 weeks. So there are three indications of pessary. Number one, if in the old lady there is lot of morbidities, then anesthetist says no, I'm not going to anesthetize your patient even for 1 minute, then pessary. Number 2, if it's early pregnancy, up till 18 weeks. To prevent the prolapse, we can put breastfeed. Number 3, if the lady is in the puerperium phase. Okay, so you have to learn these 3 indications. Okay, see, this is a question. Okay, now here I just want to tell you how there are a lot of name, isn't it? So how you are going to learn this name? Okay, I will help you, and that is the method how I do it. Okay, so first of all, that you know that whose family is not completed, we will go for a sling. Now in whom the family is completed, the surgery name is Father Gill and Manchester repair. So in whose family is completed, it means the couple has become father and mother. So F for Fothergill and M for Manchester, it means that they have become father and mother. So father mother surgery, the name of the surgery is father mother. Okay, now the ladies which are more than 40 years, their name of their surgery is Ward Mayo. So you can see that Ward Mayo sounds similar as like grandma, right? Okay, grandma. So grandma does not need uterus, so we can do vaginal hysterectomy. Ward Mayo, grandma. Okay, now how will remember the Lee Forte name? Now see, we our patient was in problem, but this anesthetist doctor said, no, you can't do surgery, but we have a surgery, Lee Forte colpoclasis. So we will tell the anesthetist, ले फिर कर दी हमने, ले फिर कर दी, हमारी भी सर्जिकल स्किल्स है, हम छोटी सर्जरी कर देंगे. सो ले फिटो, लुक आई हैव डन, लुक what if you have said like this, le फिटो. Okay, so now let's see the questions. This was a question from FMG June 22. 24 years old nulliparous female. So this is nulliparous, and this is, it has come in emergency room. The cervix is outside. It means it is third degree prolapse. Okay, and the cystocele is also there. What will be the next step? So it is quite a severe prolapse. Options are hysterectomy. No, we will not do hysterectomy in a nulliparous lady. Never. Lee Forte anterior colporrhaphy. No, we will not do Lee Forte surgery, because in Lee Forte we fuse the vaginal wall. So why we will do? If we will fuse the vaginal wall, then how the sperm is going to enter? It is the surgery for extremely old age patients, right? In which there are high morbidities. Okay. Next is the simple cystocele repair. What is simple cystocele repair? If we will repair the cystocele, how will then the prolapse will solve? No. The fourth point is pessary for temporary relief. Yes, we can give the pessary for temporary relief, because the patient with large cystoceles and large prolapse, they do suffer from urine obstruction and micturition problem. So yes, that will get relief. And when the patient is in the emergency room, we can't do any surgery. At least we can put pessary for the relief of that patient. Okay, so the answer to this question is fourth. Next is FMG December 18 question. Conservative treatment of this 60 years. This is the question from FMG June 21. NEET PG 2019 also had the same question. So 60 years old woman with uterus protruding out 10 centimeter. See, this uterus has come out. Okay, and what is the best treatment for this patient? Okay, pessary treatment? No, because it is an old woman. Why to give temporary relief? We will give complete relief. Abdominal hysterectomy. Why we will do abdominal? Then what will happen to the interior vaginal wall and posterior vaginal prolapse? Lee Forte partial colpoclasis. Why? It is not written that anesthetic is creating the problem. So the answer to this question is vaginal hysterectomy with pelvic floor repair. Okay. Let us see the next question. Conservative treatment of prolapses. Conservative means where no surgery is done. So conservative treatment of pelvic organ prolapses is yes, pessary. Okay. Now we are on the last slide. We have seen that cystocele and pectocele, they are treated by anterior colporrhaphy and posterior colporrhaphy. So how we are going to treat the patient of anteriocele and vault prolapse? Anteriocele are treated by two surgeries. They are known as McCall-Culdoplasty. Now how you will remember that this is for the anteriocele. Culdo means pouch of Douglas. Okay, Caldo means pouch of Douglas. So if we are doing any plastic surgery operation on, if we are doing any plasticity on the pouch of Douglas, we can of course correct the anterocele. So McCall Culdoplasty, you can easily remember that Culdo means pouch of Douglas and we are doing something with pouch of Douglas. Okay, I think this pen will not work. Now the next is the vault prolapse. Now what is vault prolapse? When we remove the uterus, the vagina is left. Okay, this vagina is then sutured. Then this is known as, see, this vagina is left, and after some time of the prolapse surgery, this vagina also come down, and this vaginal upper end is known as vault. Okay, okay. Oh, so camera was there. Let me move the camera here. Okay, so suppose we have removed this uterus. So now this vagina is left. The upper end of the vagina is known as the vault. Okay, some after some time this vault also get prolapse, that is known as vault prolapse. Okay, how we are going to fix this vault prolapse? It's very easy, not difficult. You all know that here there is sacrum, so this yellow is the sacrum bone posteriorly. We are just going to fix with the mesh this, we are going to put a mesh which will join this vault and with the sacrum, that is known as the mesh sacral colpopaxy. Okay, the another surgery is uterosacral ligament. You all know, posteriorly there is a uterosacral ligament. We suspend that vault with the uterosacral ligament. Yes, one more ligament is there posteriorly, that is the sacrospinous ligament. We can also suspend that ligament with the that vault with the sacrospinous ligament. So this was about the vault prolapse surgery. How you are going to remember that these are the surgery of the vault? In any surgery where sacral is there, it means that it is for the vault prolapse. And Moshowitz surge repair is for the enterocele and it is the abdominal procedure. Okay. Now let's move to the next slide. This is pessary. Okay. You all know that the vaginas is a cylindrical. Okay, I need. Yes, vagina is a cylindrical thing. Okay, these pessaries, they come in different sizes, large size, small size, medium size. So they come in different sizes. So how we will come to know that which size is appropriate for this lady? So first, with an idea, we will put in a pessary. Okay, now we will ask that lady to perform Valsalva maneuver. With performing Valsalva maneuver, if the pessary got dislodged, then it means that that pastry was of the very small diameter than required. Then we will put a bigger diameter pastry. And if on putting a pastry the lady felt discomfort, it means that we have put a large pastry, so we will replace with the smaller size. Okay, so one thing more, as you have already studied that in the patients of prolapse, the patient also had